All right. So, ladies and gentlemen, welcome back to our international ground rounds. It's a pleasure today once again to have one of our previous faculty member and speaker, Professor Narayanan Prepageran. Good morning.
Morning, hi.
So today it's going to be our third occasion for talking about anatomical dissections and the importance of anatomical dissections regarding developing a sufficient and essential anatomical, you know, research and mindfulness. So today, Professor Prepageran is going to talk about the Transplanum, clival, cranial nerves approaches, anatomical boundaries. Is it right?
Yes, of course, yes.
So it's going to be anatomical boundaries and all the anatomical structure that you will encounter if you want to perform an endonasal procedure through an endoscope. Keep in mind that what we are going to do is showing videos regarding anatomical aspects inside of the nose through an endoscopic view. All right. So good morning, everyone. Professor Prepageran, I'll leave the torch to you. Please share your screen.
Okay. So good morning, everyone. So what I will be doing today is talking about the anatomical dissection of the transplanum, clivus, and cranial nerves. So basically, the outline is we are going to do a very quick overview of the skull-base approaches. We will go through the anatomy of the sphenoid, planum, sella, clivus, and the cranial nerves. And I will spend more time on the clivus and the cranial nerves because I think the planum and the sella has been done before. And it's a much more well-discussed topic compared to the clivus and the cranial nerve. So the dissections I'm going to show you are near life because the editing we have done is very, very little, only to remove the endoscopes, to clean the endoscope. So it gives you an overview of the surgical anatomy that we do. So if we look at the coronal CT scan, you will be able to see the areas of clivus. We can see very clearly the Transclival, Transsellar, and Transplanum approaches. And this is so here we can see just a quick dissection, the overview. Here we can see how we usually keep the turbinates whenever we do dissection. And here's an overview of the entire skull base that has been exposed. We usually do not remove the turbinate. That's the orbit, as you can see. And this shows us the anatomical, that the transclival will be this portion. This will be the transcliviform. From the anterior wall of the sphenoid sinus, this will be Transsellar. And here will be the C1, C2 dissection. And that will be the endoscopic nasopharyngectomy, as you can see. So let me start with a module of a Transsellar, transtubercular, and transplanum. Again, the idea of doing a dissection is to do like how the pilots do a flight simulation. So you want to do exactly like the way you would perform a surgery, the same principles where you go layer by layer, and you use the same instruments as much as possible as well. So with that, we will start with the dissection of Transsellar. So then let me just go a little bit quickly so that I can start at the right point. Okay, so this is the transcliviform approach, as you can see here. So this is the sphenoid sinus, as you can see. From the anterior wall of this, that's the posterior ethmoidal artery. That's the anterior wall of the sphenoid sinus here, as you can see. And this portion from here, this becomes the planum. From the anterior wall of the sphenoid sinus all the way to the sella, that is the planum. And then this, the sella itself will be transtubercle and transsellar. You can see that the sphenoid sinus is not well pneumatized. It's optic and carotid artery. And again, here is the optic and carotid artery. It's not a pneumatized sphenoid sinus. So if you see a dissection of a not so pneumatized, is much better as well. That's the pituitary gland, the paraclaval carotid, and so on, and on right and left. And that's transcliviform. That's Transplanum. That is a tubercle, Transsellar, and here would be the Transclival. So that is the skull-base approaches that that we need to do. So what we would do next is to drill. Usually, if you have a pituitary tumor, the tumor would have made this bone much thinner. But in this case, as you can see, the sphenoid is not so pneumatized. Therefore, we will need to drill. The optic would be here, the carotid would be here. So we usually use a stylus drill. And doing this dissection, the drill that we had was quite tiny, as you can see, but usually in real life, we would use a large diamond drill, stylus diamond drill. And the idea is to thin the planum as well as the sella. And once we have thinned the planum and the sella, we are able to, sorry, let me just go back here a little bit. Okay, there we go. So once we have thinned the planum and the sella, we're able to see the dura quite nicely. So once we're able to see the dura, you can now make out and remove the thin bone over the pituitary itself, the transsellar itself. So once we have made the bone quite thin, we can use a Carrison punch. And by using a Carrison punch, we can now remove the bone over the sella. So quite often, most of the time, you will find in cadaver, the dura is attached to the adherent to the bone itself. So it can be quite difficult to do this dissection and preserve the dura. Whereas in real life, the dura is extremely thick, it's tough. And you'll be able to do this dissection and remove the bone over the sella and the planum quite easily as well. So what we're doing now is by using a Carrison punch, we are removing the bone over the pituitary gland itself, and we need to expose the entire pituitary gland exactly like how we do in real surgery. So we're doing it exactly like how we would do in real surgery. So this is like a flight simulation, like a trial one. So the idea is whenever to expose it for pituitary, you want to get the so-called four blues, which is the cavernous sinus on the right, cavernous sinus on the left. That will be the junction between the planum and the sella. And that's when you'll be able to identify the superior intercavernous sinus. That's the superior blue. And the inferior blue will be the inferior intercavernous sinus. Here you can see the cavernous sinus portion coming into view, as you can see here. And then this would probably be the exposure that we would require for pituitary gland. So now we are coming to the intercavernous sinus, the superior intercavernous sinus, as you can see at the top here. So once we remove this exposure will be more or less adequate for a pituitary surgery in real life. So once we have done this, we will carry on to do the dissection to expose the bone over the planum as well. Again, in real life, removing the bone over the planum without carrying the dura is much, much easier. Now we are going along the optic nerve. That's the paraclaval carotid and the carotid siphon. So the bone over the planum is going to be removed. There, as you can see, that's a small rent in the dura. And here you can see, because we've thinned the bone, we can just flick the bone away. It's quite difficult to preserve the dura in most cases in transplanum in cadaver. In real life, it's quite easy to preserve the bone. So once we have exposed that, we can open up the planum. Now we're opening up the planum. And now we're going along the optic nerve on the side as well. So that is the sella that's opened up. And you can see this video editing is very, very minimal. So what you're seeing is almost live. So now we're coming along the carotid artery. We're going to expose the carotid artery. That's the carotid artery being exposed there here. That's the carotid artery here. So now we are going to go along the optic nerve and expose the optic nerve. So all this is done by using a Carrison punch after we have drilled off the entire planum and made it thin. So once we have done that, let me just go a little bit forward so that we can go straight to the main dissection itself. So now you see we have opened up the sphenoid sinus quite nicely. You can see the paraclaval carotid. We removed the floor of the sphenoid sinus as well. So here now is the exposure of the planum and sella. All right. So this video, as I told you before, is very minimal editing, and you're seeing it as if it's real life. So it gives you an idea how quickly the dissection can be done as well. So that's planum, that's tubercle, this is where the tubercle would be, and then this would be the sella, and that will be the clivus here. So this would be the pituitary gland, and that will be the transclival. That's the carotid artery, cavernous sinus region, and that's the orbit. As you can see, the orientation between the orbit and the cavernous sinus. The next step we want to do is we want to open up the pituitary gland. Right? So what we do is we can open up just the two duras of the pituitary gland, and then we make a cruciate incision over the pituitary gland itself, and that will expose the gland. So now we can remove the tumor of the pituitary gland and preserve the normal structures. The next dissection we want to do is to dissect between the pituitary gland and the cavernous sinus. So if you go in the right plane and dissect between the pituitary gland and the cavernous sinus, that's the carotid, sorry, that's the carotid artery. My apologies, carotid artery. You can see the plugs in the carotid artery. You dissect the pituitary gland from the carotid artery. You can roughly make out the superior hypophyseal artery coming into view. The carotid artery, and dissect it so without touching the carotid artery, and then you can see the superior hypophyseal artery coming into view here, and then the same thing that we do on this side as well. We dissect the pituitary gland from the carotid artery on the right side, make sure we don't touch the artery accidentally, and we can easily identify the superior hypophyseal, and now identify the inferior hypophyseal artery as well. That's the carotid artery, and you can see the inferior hypophyseal coming into view. And with this now, we dissect the ligaments, and as we dissect the ligaments, we can do a pituitary translocation. That's the inferior hypophyseal artery supplying the pituitary gland. And by cutting the ligaments all around the pituitary gland, we can actually translocate the pituitary gland superiorly, maintaining the blood supply with the superior hypophyseal artery, and that gives us now the posterior clinoid, as you can see. So here you can see the carotid on the right, the carotid on the left. That's the posterior clinoid, is the upper 1/3 of the clivus. This is the middle 1/3 of the clivus. So now let's move on to the dissection of transplanum itself. So what we're going to do now is we're going to open the dura along the optic nerve. So as we cut along the dura of the optic nerve, you can see how thick the dura that runs along with the optic nerve. So to injure the optic nerve in real life is not easy because the perineural sheath along the optic nerve is quite thick. And you can see how much we need to cut before we can see the optic nerve proper itself. So once we've exposed that, you can see the ophthalmic artery here. Very nicely, you can see how thick the dissection, how thick the nerves are, how thick the perineural sheath that we need to cut before we're able to see the optic nerve. And that's the ophthalmic artery, as you can see very nicely there. That's the ophthalmic artery that's coming from the carotid artery, running underneath the optic nerve. Very nicely seen on the left side as well. So the same way, we will be doing the dissection, the ophthalmic artery on the opposite side. So now we're going to dissect the right side, and that's the ophthalmic artery here. That's the optic nerve on the right side, and that's the ophthalmic artery that's coming from the carotid artery, running inferiorly to the optic nerve, as you can see. Once we have done that now, the next step for us to do this ophthalmic artery here very nicely, as you can see, and the ophthalmic artery on the left side. Now we are going to open up the arachnoid at the planum. And when we open up the arachnoid in the planum, we will be able to see the ACAs. So this is the ACAs coming into view. By using a sickle knife, you're going to dissect the ACAs away. And now we can see the right and the left ACA. So this is the right ACA, that's the left ACA, that's the intercommunicating, as you can see there. The right ACA, the left ACA, that's the intercommunicating. Once the intercommunicating, you have A1 and A2. You also have the artery of Hubner that goes downwards along the ACA as well. That gives us a very nice view of the ACA. So once we have done that, we now dissect along and remove the arachnoid to see the pituitary stalk. So here you can see the pituitary stalk coming very nicely behind the optic chiasma. All right? So that is the right optic nerve, pituitary gland. If we translocate, you can see the posterior clinoid, as you can see. And here you can see we have preserved the superior hypophyseal on right and left. And then that's the optic chiasma. right optic, left optic, optic chiasma. And if we go backwards, you can see the optic radiation, the optic tract, and the optic radiation that goes to the occipital. That's the optic radiation going to the occipital. And if we go between the optic and the pituitary gland, we can already see that's the membrane, Lilliquist membrane. That's the membrane that separates the basilar artery region. So if you dissect the Lilliquist membrane, we are actually now able to look at the basilar artery itself. So that's the basilar artery coming into view. And that's the mammillary bodies. That's the basilar artery. That is the posterior cerebral. That's the P1 or the intercommunicating, the posterior intercommunicating, the anterior intercommunicating. And that is the superior cerebral artery, and that's the third cranial nerve. So you can see the view that you get from here. So let me just go a little bit quickly in view of time tonight. Okay, so very quick overview of the transplanum and Transsellar. The pituitary gland, optic nerve, carotid artery on the right. That's the paraclival carotid on the right side going into the carotid siphon. And this is the left side paraclival going into the carotid siphon. And that's the pituitary gland. We can do a translocation, as you can see here, with the superior hypophyseal arteries that is kept intact. And now you can see the pituitary stalk as well. That's the carotid artery coming from the paraclival, forming the carotid siphon, as you can see. And that's the inferior hypophyseal artery. And then if you go backwards, you can see the optic nerve and the ophthalmic artery coming into view, as you can see. And if you go back between the optic and the pituitary gland, we can see the basilar artery, the posterior cerebral, that's the posterior cerebral P1, and that's the superior cerebellar with the third cranial nerve. So now, this is another view that shows the optic nerve on the right, optic nerve on the left, pituitary gland, right and left ACAs with the intercommunicating. And this is another dissection very quickly to show the paraclival carotid on the right side, on the left side, that's the pituitary gland, that's the pituitary stalk. What makes this dissection a bit unique is that the cadavers are injected very nicely, and you can actually make out the superior hypophyseal artery from the right with the inferior hypophyseal artery. Can you see that, guys? Very clearly seen. And you can see the inferior hypophyseal artery on both right and left and how they are anastomosing in the center. So that's what makes this dissection a bit unique. Yeah? So now, this is a dissection that I did in Mumbai just a few months ago. You look at the clarity of the video. That's the technology that India has got now. It's amazing. See how clear the dissection, the camera system that they have, right? Incredible India, that's why they call India. So what I'm going to do is I'm going to cut the planum, and I'm going to open up the planum. And when we open up the planum, you can see the anterior cerebral vessels very nicely, right? So that is the right ACA, that's the left ACA. You can see sometimes the ACAs are not the same size. The right is much bigger than the left. And you can see the humeral artery coming into view. That's the intercommunicating, as you can see, right? That's the intercommunicating. There's the A1, that's the A2, intercommunicating, and right ACA. Very nicely dissected and seen. You can see the frontopolar artery coming from the left side here. That's the frontopolar artery coming here, and the artery of Hubner. So this is the dissection of the ACA right and left, and the left is much bigger as well. So now let me go on to show you the dissection. I'm just going a bit quickly of the third ventricle. Okay. So again, you can see the right and the left optic nerve, optic chiasma, that's the pituitary stalk. So right optic, left optic, pituitary stalk. We're going to dissect away, that's the MCA that you can see here. So what we're going to do now, we're going to dissect away all the perforators so that we're able to visualize the mammillary bodies. So that is the mammillary bodies, as you can see. Sometimes you are able to visualize the basilar artery. That's the membrane of Lilliquist that is separating the basilar artery region from our view at the moment. So now let's just suck up all the blood from that area and identify the mammillary bodies. So that's the mammillary bodies coming into view. So if we open up the mammillary bodies, you can see that's the third ventricle. So now what we're looking inside is the third ventricle itself. There's probably a interpeduncular adhesions. And let's see whether we can open up the third ventricle a little bit bigger. So again, these are unedited videos. As what you're seeing is almost live as how I was doing it in Mumbai a few months ago. And now we're going to open up the third ventricle a bit larger, and let's see whether we are able to visualize the third ventricle a bit more clearly. So again, I'm going to enlarge the third ventricle. We will be having a perfuse CSF leak. Now we are looking into the third ventricle itself. And there's a CSF leak that is gushing from the third ventricle. And hopefully we'll be able to see the choroid plexus after a while. And that's the view of the choroid plexus. Can you see, guys? That's the choroid plexus very nicely seen in the third ventricle itself, right? So it's not often you get to see a view like this in a cadaver. In real life, you can see, but not in a cadaver. Let's go on to transclival brainstem anatomy, okay? So here again, you can see there's a paraclival carotid on the right side. That's the paraclival carotid on the left side. So this is the clivus. It's not a great clivus because the clivus itself is quite narrow. And usually the boundaries of the paraclival approach would be you need to drill from the sella all the way to paraclival on both sides, all the way to the floor of the clivus, okay? Again, this is an unedited video or very minimal editing. What you're seeing is almost live, as you can see. So the trick of doing a paraclival is to drill right in the center. And once you have exposed the dura, you can use a Carrison punch there. This is the trabecular region, is the clival plexus that bleeds quite a bit during a paraclival approach, a transclival approach. So what we're going to do now is once I've got a space, I will start using a Carrison punch, and then you can expose the clival dura quite easily by using a Carrison punch, as you can see, right? So usually the pathology that we do for transclival would have eroded the transclival venous plexus, and therefore the bleeding wouldn't be substantial. If the venous plexus in the transclival region is still patent, we can have sometimes quite significant bleeding as well. So I'm going to remove the bone over the transclival. Let me just go through it quickly to show you. Okay, so now we are going to remove the posterior clinoid as well. I've drilled the transclival. So when you do the posterior clinoid, it's very important that you bite through and through because you're very close to the carotid artery on both sides. Do not pull. When you pull, you can see the entire carotid artery is locking because there is a ligament around the carotid artery that is adherent at the posterior clinoid here. So what you need to do is you need to bite through and through without pulling. And therefore, this gives us a good exposure to the upper clivus as well. The posterior clinoid is the upper 1/3 clivus. And if we need to bite it through and not pull it, otherwise that will cause a tear in the carotid artery. So now the transclival is completely exposed. So what we need to do now is to open up the transclival. As we open up the transclival, the dura, now we will be able to see the basilar artery. So that's the basilar artery coming into view, as you can see. The basilar artery is not always straight. It's usually, sometimes it's curved to the right, sometimes it's curved to the left. You can see the atherosclerotic patches that this patient has got as well. And that shows the basilar artery turning from the left towards right as well, right? So here you can see the posterior cerebral, superior cerebellar, the third cranial nerve, that's the P1, the anterior intercommunicating. And here you can see the posterior cerebral, superior cerebellar, and the third cranial nerve as well. So this is a 0-degree scope. So to make our exposure bigger, what I'm going to do is I'm going to use a Carrison punch, and I'm going to bite the dura a little bit more so that we have a better view. So I'm going to use a Carrison punch and bite a little bit more to have a better view. And now we are going, that's a view that we get with 0-degree scope. So now let's use a 30-degree scope. Remove a bit more dura. And let us start using a 30-degree scope. So once we have exposed the dura on either side to make the exposure much bigger, then we can use a 30-degree scope to have a look inside. All right, okay, there we go now. So this is still a 0-degree scope. And you can see the approach of Transclival. I'm going to remove a little bit more bone. It's very important when you come laterally here because the sixth nerve comes very close laterally. That's the sixth nerve coming into view, as you can see. And it's very important that we don't damage the sixth nerve as it comes. Now I'm going to use a 30-degree scope. So now you can see the sixth nerve on the right side. Look at the direction of the sixth nerve on the right side and the direction of the sixth nerve on the left side. It goes lateral to the paraclival carotid, into the Dorello's canal, into the supraorbital fissure, and then it goes into the orbit. So that's the sixth nerve. The direction is completely different, as you can see. So now let's look. You can see the basilar artery coming into view down here. Now that's the sixth nerve on the left side, going to the lateral to the paraclival carotid, into the Dorello's canal before it goes into the supraorbital fissure, into the orbital fissure. And now let's have a look at the cranial nerves. So here is cranial nerve number 3, as you can see. That's the superior cerebellar. That's cranial nerve number 3. Okay, that's cranial nerve number 4. The big guy here is cranial nerve number 5. Why is it so big? Because it supplies all the muscle, all the sensation to the face. And then if we turn our 30-degree scope, if we turn our scope now again, third cranial nerve, that is the fourth cranial nerve, that's the fifth cranial nerve, as you can see, going into the petrous apex there. That's the 7 and 8 cranial nerve into the IAM with the ICA, 6. 5, the big one, 7 and 8 into the IAM. And now down you can see the jugular foramen. That's the 9, 10, 11 going to jugular foramen. And down here you can see the vertebral artery. And this is the first C1, the multiple rootlets of C1. Okay. So again, basilar artery, an overview again. Posterior cerebral, P1, the superior cerebellar, the third cranial nerve. It's big because it supplies all the muscles of the orbit apart from lateral, rectus, and superior oblique. That's the fourth cranial nerve coming from the back, as you can see. The big one, the fifth cranial nerve, because it supplies all the sensation of the face and the muscles of mastication. Rotate the scope, you can see the 7 and 8 going into the IAM with the ICA. That's the 7 and 8 going into the IAM with the ICA, as you can see there. This is the 6th. And way down here is the jugular foramen with 9, 10, 11. And here will be the 12th cranial nerve. And that's the vertebral artery, as you can see here. All right? That's the vertebral artery, and that's the C1. Vertebral artery forming the basilar artery. So this is a picture that was taken in Cape Town, and this was taken with a Samsung phone, but it shows us very nicely the anatomy as well. So again, that's the basilar artery, the posterior cerebral with the intercommunicating. That is the superior cerebellar. That's the third cranial nerve, as you can see. And the same thing here as well. That's the right posterior cerebral, superior cerebellar, P1, third cranial nerve. And here you can see the mammillary bodies that's open. And that shows us very nicely the third ventricle here as well. All right. So let's go to the anatomy of the cranial nerves again. So this shows us the fifth cranial nerve. The big one is always the fifth cranial nerve. The fourth cranial nerve comes from the back of the midbrain. Usually you cannot see this. Very small, it's the longest intracranial nerve. Fifth is always very big. 7 and 8 goes into the IAM, as you can see with the ICA. And now another view of 4, the big 5, 7 and 8 in ICA. There's a jugular foramen, as you can see. All right, so you have 9, 10, 11. And let's see another view here again of the IAM, the nerve 7 and 8 with the IAM. And this is now a view of 5, 7 and 8 here, 9, 10, 11. That's ICA, that's PICA. So ICA goes with 7 and 8, PICA goes with 9, 10, 11. Okay. So again, a very nice view of the fifth cranial nerve, the fourth cranial nerve. The fifth is always the biggest nerve. You can see very nicely the internal auditory meatus here, how the 7th and 8th nerve complex goes into internal auditory meatus with the ICA. And down here would be the 9, 10, 11 with the PICA as well. So let's now look at all the cranial nerves. Okay, a few more videos of just repetition sometimes is good. to make us remember the anatomy, right? So again, the first cranial nerve, the olfactory bulb, as you can see, that's the first cranial nerve. The second cranial nerve, the optic nerve on the right, the optic nerve on the left, forming the the optic chiasma tract radiation. That's the third cranial nerve between the posterior cerebral, superior cerebellar. Okay, that is the fourth cranial nerve, as you can see, coming from the back of the midbrain. The big guy here is always the fifth cranial nerve going into the Meckel's cave, as I showed you the last dissection. That's the seventh and eighth nerve going to internal auditory meatus. You can see very nicely how it divides. That's superior vestibular, inferior vestibular. That's the 9, 10, 11. This is the 6. And so IAM 7 and 8. And way down here is the 9, 10, 11 complex here. So IAM 5, 7, and 8. And way down here is the basilar artery, the spinal cord. And this is the C1 rootlets, as you can see. So this shows us very nicely the C1 rootlets, vertebral artery forming the basilar artery as well. The fifth cranial nerve, 7 and 8, sixth cranial nerve. Okay, so this is a very nice view to show you the lower foramens. This is 6, the big one is 5, and there's a 7 and 8 complex going into the internal auditory meatus here. That's the IAM, as you can see, with 7 and 8 with ICA. And this is a very nice view. That's the 7 and 8 with ICA, 6. And lower down here is a jugular foramen. And you can see 9, 10, 11. The multiple rootlets is 9, 10, 11. And you can see the multiple rootlets of 9, 10, 11 going into jugular foramen. So this is a very nice view of jugular foramen with 7 and 8. 5, 7 and 8, 9, 10, 11. With 12 coming from medially here as well. And that is 6. And that's the vertebral artery going downwards, as you can see. Right? So another dissection as well. Yeah. So I'm just going to go a bit quickly so I can show you the anatomy again as well. The vertebral arteries meeting to form the basilar arteries, as you can see. So let's go to the cranial nerves again. That's cranial nerve number, that's the posterior basilar artery, posterior cerebral, superior cerebellar, and that shows us the third cranial nerve. And then when we go inside here, the big one, the fifth cranial nerve, and we go deeper inside, 5, the biggest nerve, 7 and 8 in going into the IAM, as you can see. That's the 9, 10, 11 with the multiple rootlets. This is 6. Okay, very nicely say. 5, 7 and 8, 9, 10, 11. 7 and 8, 9, 10, 11, and that's 5. Very nicely said. That's how ICA and PICA. ICA goes with 7 and 8, PICA goes with 9, 10, and 11. Another TransClival. So these are all different TransClival that I've done for dissections. The big one, 5. Okay. Small one, 4, 5, 7 and 8 going into the internal auditory meatus, and that's ICA following the 7 and 8 complex. And down here is 9, 10, 11. And that's PICA going with 9, 10, 11. And lower down there will be 12, going medially by originating more anterior than the 9, 10, 11, 12. So this is, I think, the last 2 videos I'm going to show you. So this is the cranial nerves again. That is the olfactory nerves, as you can see. Let me just go a bit quickly. Okay, again, this is the optic nerve left, optic nerve right. That's the olfactory tract. Now we are going into transclival region now. Let me go a bit quickly again. Sorry about that. Let me go a little bit quickly. There we go. That's the third cranial nerve. That's the basilar artery that's completely turned to one direction. It's completely turned to the left side. Posterior cerebral, superior cerebellar, the third cranial nerve, as you can see. Can you see how the basilar artery is completely turned in one direction? That's why I want to show you different dissections, because you get the different anatomical variation. Posterior cerebral, superior cerebellar, see how the basilar artery is completely turned. And now let's use the 30-degree scope and look at the other cranial nerves. The big one, 5, correct? The small one in the back, coming from the back, that's 4. This is 5. This is 4, is coming from the back, one small cranial nerve. This is 7 and 8 complex. That's the IAM going, that's the 7 and 8 going into the IAM, as you can see. That's the 9, 10, 11, the multiple rootless going into the jugular foramen, as you can see very nicely here. And that is 6th cranial nerve. And lower down here is the basilar, is the vertebral artery. And these are the nerve rootlets of the C1, and that's the upper cervical spine. Last video, okay? So let me show you again the, this was done in Bombay. That is the foramen of Monro on both sides of the third ventricle. That's the choroid plexus. By using a 30-degree scope now, we are going to actually look into the lateral horn. That's the lateral horn of the cavernous sinus, and that's the blood, that's the stria vascularis, or the vein that supplies the stria vascularis, as you can see here, the choroid plexus here. And then we can also look at the aqueduct of Sylvius. From the third ventricle now, we are going to join the fourth ventricle. And now we are looking at the fourth ventricle. So let me just suction out the CSF from the fourth ventricle. And now we are looking at the choroid plexus region as well in the fourth ventricle. Aqueduct of Sylvius, and that's the choroid plexus from the third ventricle coming downwards with aqueduct of Sylvius. The same way now, if we do a transclival for this patient as well, by using a J suction, we're going to push the brainstem away. And this shows us very nicely the view. That's the 6th cranial nerve, as you can see here, coming into view. The big one is the 5th cranial nerve. This is a very nice view, as you can see. This is the 5th cranial nerve forming the Meckel's cave. The big one is always the 5th cranial nerve. The 6th cranial nerve down here, that's the 4th cranial nerve. So 4, the small nerve. 5, the big one, going to Duelos Canal. 7 and 8, complex, and that is the 6th cranial nerve. So look at the clarity of the videos, the recording system in Bombay, in India. Incredible, isn't it? 6, 5, 7, and 8, very nicely seen, as you can see. Okay, so last overview, let me go to 251, and if we're done. Okay, let's go. So the last overview, okay? Optic nerve on the right, ophthalmic artery. You can see very nicely the ophthalmic artery going to the optic nerve on the right. That's the optic nerve on the left. That's the ophthalmic artery on the left, as you can see. Okay, and here we can make out the ICA. That's the optic chiasma, optic radiation, optic tract, optic radiation going all the way to the occipital, as you can see. And here, that's the ICA, the right ACA, left ACA is intercommunicating with the frontopolar as well as the artery of Huebner. And then you can also see very nicely the ACAs. And then you can also see the MCA and the third ventricle, foramen, Monro on both sides. And that's the choroid plexus, lateral horn, as you can see. All right. So I hope that was clear. There was a lot of repetition because I think to understand the cranial nerves in Transclival, it's good to see different dissections in different countries, but you can see that there are some changes depending on how the basilar artery runs. But as long as remember the big is 5, the 7 and 8 complex goes to the IAM with ICA, 9, 10, 11 complex go to jugular foramen with pica, you should be okay. I hope that was clear. Thank you very much.
Everything was more than clear, I guess. It was unbelievable and, of course, brilliant as usual. So
I can't hear.
There's.
Hello?
Can you hear me? Can you hear me? Hello?
We can't hear anything.
Can
you hear me?
Can you hear me? Yeah, I can hear you.
Hello?
Let me see.
Yes, yeah. Now I can hear you. Sorry.
Oh, great, thank you. So there's a lot of compliments from audience, of course. Many different questions, of course. Even if some of the questions are related exactly on the fact that sometimes, in order for you to express what were the nerves, you did not mention we are in the left side or in the right side, so that makes some confusion. So in order to reply, I will go for some questions, and then if you can please show the one of the last videos, amazing quality that you did in Mumbai, express exactly the position. I think you were in the left side, so you have to manage and tell them what are those critical landmarks. Before going into that, I would suggest and stress all of our videos are you can watch all our videos on our YouTube channel. Please also remind that there's also in a YouTube channel from Professor Prepageran. You can also watch them in there. So anatomical dissection are available. Surgical intervention also are in there, and you can just go there and watch our previous ground rounds. In fact, regarding Meckel's cave that we did before, and Sella and all that. So in order to go again with the slides, because you have to reshare it, few questions. The first, do you recommend to drill more before using Carrison?
That's a good question. It depends on how much bone there is. Usually when you do a transclival, it's usually for chordomas or meningiomas. Sometimes in chordoma, most of the time the bone is gone. And therefore the amount of drilling requires very little. Sometimes you don't even need to because the tumor has already gone through. If the clival is thick, then you need to drill. But the idea is to drill enough to make the bone thin, and then you can use Carrison. So the answer to the question, it depends a lot on the pathology, the amount of how thick the bone is. But the trick is always to make it as thin as possible and then use Carrison if required.
Yeah. Another thing that I would like to stress, and back in 2015 when we're that Milano master class, so with those anatomical dissection pre Congress, one of the suggestions from Amin Kassam was to reaching and opening your space to get in the cranial pelvic rejection or clival was to remove part of the eustachian tube, because we'll open up the space of a 1/3. Would you please suggest us what can be done to prevent damages after those kind of dissections?
Usually we don't cut the eustachian tube, because usually once you cut the eustachian tube, the patient will usually have a lot of middle ear problems and complications as well. So if the clivus is too narrow, if the paraclival cavities are too narrow, then there's always the option of doing transcranial. There is no need to do all surgeries endoscopically just because we're doing endoscopic dissection. And if you ask the neurosurgeons who do this often as well, they will tell you that maybe 40% of the time they do it transclival, but 50 to 60% of it, they will actually do open surgery. So if the clivus is too thick, the carotid arteries are too close, don't attempt transclival. You must always choose the case based on the pathology, based on the expertise.
Yeah. By meaning of that, I don't want to see that. I don't want to tell that. I mean, was telling you have to do it like this. That was an anatomical dissection.
Yes,
And in
not.
fact, yeah, of course, that's a difference. That was the importance on how to get more spaces.
Space,
Then
yes.
one thing that you stressed was the the blood that you would encounter when you go for a clival approach. When you get out the pharyngobasilar fascia, what are the structure that you have to take consideration, like from vessels? So what are those structures?
There's a clival plexus that runs just before the dura. This clival plexus you could see the tuberculase that was present even before we opened the dura. It's just before the clival dura. It's in the bone marrow of the clivus itself. So the bone marrow of the clivus itself can bleed. And the clival plexus is an extensive venous plexus that can bleed profusely. And I've known of cases where they could not even proceed with the surgery. They actually had to stop the surgery because there's too much of oozing. So sometimes they use a gel foam flow seal pate, pack that area, and come back again after a few days to do the surgery. That can also happen. That's how bad the bleeding can be. Luckily, most of the time, if you select your cases well, the tumors would have caused these plexus to be thrombosed. then it's much easier to do the surgery. So it's all about case selection. Just because we are doing a transclival dissection doesn't mean that we should do all the cases by endoscopically. If the clival is very thick, the bone is very thick, and the space between the carotid arteries are too narrow, and the tumor has not thinned the bone sufficiently, maybe we should think of another approach. The bleeding from the transclival plexus can be very significant in a lot of cases. So transclival, I think, is a very good approach if the tumor has eroded and thinned out the clival bone and the clival plexus is thrombosed, then I think it's a very good approach.
Yeah, it's mandatory what you say. Case selection is important.
Exactly.
Taking advantage of what the pathology already done for you will allow you to get more confidential in that area. So, in order
Excellent.
to do
Yes.
it, the questions were exactly regarding this, regarding how to deal with the bleeding in this area. Many compliments, of course. And can
Thank
you
you.
please once again share your screen and pinpoint by telling the left and right for each one of those cranial nerves. And meaning while you're doing this, I would like to stress the importance. Would you understand, all colleagues, please, that in the last 15, 20 years, we completely changed our attitude from open approaches we can reach to pathologies and watch anatomical structures by just going inside the nose, lowering the morbidity of the patients, and trying to reach to places that was impossible 20 years ago. So by saying that, I don't want to, tell anyone that you have to do it like this. It's an anatomical demonstration. So keep in mind that what you are, let the people know is for anatomical purposes, which is
Exactly.
different
Yes.
from a surgery.
The life surgery. Yes.
So please, would you share once again your screen?
Sure. So the screen is on. So I'll
Yes.
just show you two videos. So all the anatomy I'm showing are all on the left side. They are all on the left side. So I think that will make it easier. So I'll just show two screens again. Yeah. So first of all is all 12 cranial nerve. Oh, sorry. So here, as you can see, that is the olfactory nerve, right and left. That's the optic nerve on the right, optic nerve on the left, forming the optic chiasma, and this the left optic tract and radiation. That's the basilar artery. Now we are going to the left of the patient. That's the left posterior cerebral and the left superior cerebellar, the left third cranial nerve. That's the left fourth cranial nerve. That is the left fifth cranial nerve going into the Meckel's cave. And then this is the left sixth cranial nerve. This is the left 7 and 8 complex with ICA. And this is the left jugular foramen with 9, 10, 11. And here is the right basilar and the left basilar with the upper cervical. All right. So again, 5, left 5. These are the vertebral arteries, right vertebral, left vertebral artery. That's the 11th nerve. And I show you again, let me just, okay. This is the left 5th. This is the left 7 and 8 complex. IAM is here with ICA. This is the jugular foramen. 9, 10, 11 will go into the jugular foramen with pica. And this is the 6th cranial nerve. So now let me go on to the dissection from India, which I think is this one here. Okay. So here I will show you that. So here, let me get a nice view, then I'll stop. Oops, sorry about that. Here, as you can see, now what we are looking is, again, we are on the left side. This is the 5th cranial nerve going into the Meckel's cave, right? So this is the 6th cranial nerve. That's the 7th and 8th cranial nerve. That's the 4th cranial nerve. They're all on the left side. The left 4th cranial nerve, the left 5th cranial nerve, the left 7 and 8, and the left 6th cranial nerve. Left 4th, left 5th, 7 and 8 complex, and that's the left 6th. Okay, so just to finish, and this is the dissection of the right optic, left optic, optic chiasma, optic tract on the right side, going to optic radiation, and that's the right ACA, that's the left ACA, and that is the intercommunicating between the right and the left ACA. All right, so is that okay?
It's perfect, and everything
go back to Zoom.
Everything was cool, everything was fine. So I think that, you know, providing the people the importance of knowing where they are is mandatory. So that's why I've stressed. I'm sorry for bothering you.
No problem. No problem.
Thank you, Professor, once again for being with us, for teaching anatomy, which is essential. I think that many of the surgeons now want to go back, you know, from education training. It's and they, you know, taking advantage of this time to get ready for the future. We do have the opportunity to learn from each other right now, and it's you know, low cost, and we can get all around. So why it is important? Because we have to face sometimes emergency, and we cannot perform surgery. So cadaveric dissection could be a potential way in which students or residents could learn without, you know, being affected or get, you know, exposed to pathology, and they do have to keep their training done. So this is a good way to get those things running out. So thank you again. We will have Professor Prepageran for the future, of course, for other panels. I would like to invite all of you for an appointment of tomorrow. I'm very glad to have one of my brilliant colleagues. I've been with her for a while I was in London. Catherine from Catherine is going to talk about the cystic fibrosis and chronic rhinosinusitis. So it's going to be a good talk tomorrow. And then the whole week is going to be amazing. If anyone would like to have more information, please watch and visit our Facebook page. If you want to contact and watch YouTube channel, please Associazione Naso Sano. And if anyone want, Professor Prepageran, would you like to share which is the name of the YouTube channel of yours?
Okay, I'll just let me just share the screen for one moment, yeah?
Sure.
There you go. So that's perfect. The ENT skull base UMMC.
Perfect. So anyone would like to get more information, YouTube channel Associazione Naso Sano or ENT skull base UMMC. Thank you everyone for being with us.
Thank you.
Thank you once again. Please do remind that all of our ground rounds are you can participate in that by simply checking out with the same link and the same ID number. But you can also visit live on Facebook, YouTube, Twitch, LinkedIn, everywhere, multi-stream. Thank you so much, everyone.
Thank you. Ciao.
Grazie, Professor Prepageran, and I'll see you very tomorrow for the others. Thank you.